the concept of retail healthcare. Heather, you mentioned price transparency and getting your estimates right so that people know what they're going to owe. And then on the patient side, Kevin, just a couple of days ago, we were talking about consumerism and how it's not a new concept, but it does seem to be getting some wind in its sails. When you're talking to some of these larger systems, what are their plans for being able to capture the market share in order to have patients, make it convenient, make it understandable what it's going to cost and where they should go and how the whole process is going to work?
We use the phrase in healthcare, access, and it's a single word, but it means a whole lot of different things. Access is physical access. Access is logistical, and cost is involved in that as well too. And certainly Brian brought up the whole, the ease of the access. So sure, I might have an appointment, but getting downtown, walking the mile, this is not physically possible for me. So it doesn't work out as well. So you have to put all of those things out. And I think you have to look hard sometimes with COVID and say, where are the bright spots, some of the silver linings that are out there. But one of them is that realization that, things can be done and they can be done fast. And what do I mean by that? Like telehealth, telemedicine was something that everyone dabbled in it. For the last 20 years, I've been talking to people, and if I've heard this phrase once, I've heard it 100 times. We've got a pilot, Kevin, with our telemedicine project. And, if it works, and all right, so you flip a switch, and 2 years ago, 350 million Americans went on the pilot program. And we liked it. For the most part, it worked smoothly. Most people had the technology to do it and flip it very quickly. So we're taking that model, and like to Heather's point, we're having to break some things. So we're breaking this inpatient focus that we've got. And look, as human beings, we like things in black and white, on or off, binary switches. And the reality is this is a continuum that moves back and forth. And you can't suddenly say everything done on the inpatient is now on the outpatient. It's going to gradually move, and it has been gradually moving. So for us, it's watching folks do a lot of different things. Meeting the customer where the customer's at. Sometimes it's on the phone. Sometimes it's in front of my computer. And by the way, that took off, kind of came back down. So, the old car joke, we went from 0 to 60 in a heartbeat, but we're back down to about, maybe 15 to 20% of our visits are done, electronically, if you will. But in certain modalities, it's very strong. Psych is one. People feel very comfortable talking to a computer or phone versus face-to-face. Some dermatology can be done that way. A lot of routine OB visits, those are much higher than, if you will, the traditional. But you're not going to push that genie back in. And in fact, you need to figure out ways to grow that book of business. It's lower cost. It meets the customer where the customer wants to be met. And I think you're just going to see this grow slowly over time. Again, not push that genie back. The second one, we talk about technology. Technology is another one that's just going to be huge. And this is, again, we're talking about breaking things to make it a little bit more cost efficient. So we have, rules, regulations, and just habits that we've always done it this way. And this is one of those opportunities where you say, hey, I think it's time to revisit this. And Heather was right. Healthcare is, nothing but creative and inventive when we get pushed. And I think you'll see some interesting things come out of here with electronic nurses, if you will. You roll a pole into a room, you stick an eyeball on somebody, and normally you'd have a nurse sitting there 24 hours a day, making sure the patient doesn't get agitated, tries to get out of bed, doesn't try to pull a cord out of the wall or something. And that's just dollars sitting there when you can put an eyeball basically in a room with a voice monitor and say, patient in room 24 is getting agitated, send somebody in quickly. Cost savings. People who deliver medicine 20 years ago, right? We didn't have the technology for wanding and badging things. Now we do. So does a nurse have to administer all of the medicine? I don't know. The wanding and the badging and the swiping is pretty foolproof. So why can't anybody do that? Again, cost savings, break it just a little bit to fix it, so to speak. And that's hard and that's difficult, but it gets into transparency. I have a little bit of a contrarian viewpoint. I think definitely the transparency for me is more along the convenience factor. I prefer to go here because it's easier, faster. I don't hear cheaper a lot of the folks I talk about. So generally, the organizations I work with still go with, well, I'm part of that system. Or hospital because my insurance is part of that system. So, maybe I'm not a narrow network, but I am by definition almost a narrow network. I like my doctor. My doctor goes there, so I follow my doctor. So I don't care so much about the price, but if I have a choice between the three and this one's easier, I'll go into that one. That's easier. So for me, and what I see a lot, not so much price, I can't say it today, price transparency, more of that access transparency, that ease of getting in is going to be huge. So let me stop there. I keep talking.
No, you're good, Kevin. That's all very interesting. And on the side of price transparency, one thing we've heard is a concern over being able to put forth an estimate that's even within the ballpark and not wildly wrong in either direction. Because I hear you, if I'm having a procedure done, I'm not looking for the cheapest option. Some portion of healthcare is always going to be looking for the quality. Brian, in your time at Piedmont, did you do anything around price transparency as far as estimation and trying to nail down that horse?
Yeah, the team definitely did, and I give a shout out to the team over the years and the team that's still there trying to figure this out. And what people will tell you is the stuff that's diagnostic, we can do a really good job at figuring that out and communicating that. But anything that's interventional is really, really difficult, and there really isn't an easy solution on it. You can go back and you can look at historicals, you can look at trends, you can look at contract adjustments, you can look at all the different pieces and parts, and it is still really difficult. One of the things that we toyed around with and never did, and I've talked to a few other organizations about it over the last couple of years, which is, how about guaranteeing estimates, right? Think about when you take your car in, right? You pay a diagnostic fee a lot of times, and if they find something, they'll maybe apply that diagnostic fee to what the service is, right? But the same thing, you go in for an MRI, you have a fee. We can generally tell you what that is going to be from an out-of-pocket perspective. And then you may need something else, right? The auto companies or the auto dealers, they're able to quote you what it would cost to fix the axle or replace the brakes or whatever it is, right? And it may or may not be exactly the amount of time that they spend, but why couldn't we do that in healthcare as well? And again, if you go in and you have an issue with your leg and something else happens, just like when they get into your car, they're going to come back to you and say, well, this is what we quoted for the scope, but there's something else that gets added on. And I think if we were able to do that in healthcare, it would be a lot easier across the board. And I think organizations as a whole would come out better off.
I feel like there's a fear over guaranteeing payments because of that. I think, but at the same time, I really do feel like you're exactly right that there has to be something to just doing it and just getting it out there and starting down that path. Because like you said, the first auto repair shops probably couldn't tell you how much it was going to cost, but now everybody can.
I think we've kind of danced around this even in this discussion, but the big deal is around educating the patient through all of this, right? You say to the patient, okay, this is what your MRI was. This is what you're going to need. This is the cost. These are options that will help you pay for it. You're not stuck with a credit card to pay for this procedure. We have these options available to you. It's educating the patient. And we're living in a world where nobody understands what coinsurance is. They don't know what their deductible is. They certainly don't know what the heck their plan says. They don't know, it's very rare you're going to stumble across an American who's not in this industry that says, oh yeah, I know exactly what my deductible is. I know what in-network, out-of-network is. I know how many visits I have to go to this provider in order to get this procedure at this place. And it's all going to cost me this. We're living in a dream world if we think that 65% of Americans are living paycheck to paycheck. They're not well versed on terms of healthcare. So as organizations, to build trust with our consumers, patients, et cetera, we have to educate them. It's not, you start educating people on what options they have, they're much more likely to follow their doctor to the ends of the earth because their doctor has educated them on all of these things, right? So I think that there's something around patient education for this that is not spoken to enough or focused on enough by most healthcare organizations.
Disaggregation of how the whole thing is funded, so you might be on a PPO, I might be in a capitated plan, someone else is doing fee for service. Everyone's got different incentives and different perspectives of their healthcare bill. And, I say this a lot, and I'm actually serious about it. It's the only industry out there that you go have a service done. You don't pay for it yourself, maybe a copay or a little bit of deductible. Someone else in a basement of some building that you've never been to out of state with a PO box maybe pays that person, 60 days later. Name anything else that works that way. I can never come up with anything like that. You even pay auditors and consultants that I used to be, you pay them per month, you pay them as you go along, not after the fact at some negotiated rate. So yeah, we do not, as average Americans, have a good understanding how this whole thing works. And I always play this game with my neighbors, tell me what the average profit margin of a hospital is. And they think it's something, like Amazon or something like 25%, 30%. And they think they're pretty close. I'm like, cut that by 10 times. I mean, you're not even remotely close. These are retail margins, folks. So yeah, we don't understand the industry as Americans, and education. Wow. I don't know. I don't know if we'll ever get there, but I think we certainly need to cut out the variability in how the payments work. I think that'll help quite a bit.
The other thing I'll add, and there's a number of people who I will probably make very upset with this comment, but if you're a hospital-based physician, you have got to be on the same contracts as the facility that you're working at. There's too many organizations where these ED docs, radiology docs, pathologists, and a lot of them have been rolled up into by these private equity companies because they've been able to get out of network rates for years. But you're never going to get to the point of price transparency and being able to provide a quality estimate if you cannot get those rates defined and those hospital-based providers onto the same contracts with the facilities they're providing care at.
Yeah, well, and what a great example of what adds more confusion when somebody goes into even a small facility and they get their bill and they pay it, and then a month later they get another bill, and then a month later they get another bill. It really stacks up to what you're saying, Heather, is that there is an education, but also being able to stack the deck on the side of the healthcare provider so that the patient's getting one bill and having one experience. I think that would make a big difference. Certainly the No Surprise Billing Act feels similar about that. And it also looks to me that the insurance companies have seen this concept that, oh, well, let's have them force educate themselves by making them pay more often. Right, people will pay more attention when they have to go into their own pocket. What have you guys seen in the way of increased coinsurance and increased high deductibles, and what that impact has had on revenue cycle or on the hospital financials?
So high deductible health plans, as they keep growing, $5,000, $10,000 deductible out of the gate. I've had CFOs say, look, that deductible is basically bad debt for me for the most part. So it creates like mini cycles within cycles. So you see this a lot, and we all do it. Even as people knowledgeable about the sector, once you've reached your deductible place for you, your family, and everybody else, and everything afterwards is quote unquote free. What do? We start hitting up for all those things we want to get done. My hip hurts, my knee hurts. I'm over 50 these days. So everything hurts. Why not go ahead and get it done? It's free, kind of a thing. And so it creates, a little mini cycle within it. So you really start to see January's, February's, March's lower because no one wants to hit that $5,000, $10,000 deductible. I do think ultimately that is the way you start to drive that accountability, that ownership for your own care. I hate to say it, we're such a great country, a great industry. We've been able to fix everything with a device or a procedure or a pill that we still don't take good care of ourselves. And I think ultimately when it comes out of our dollar, our pocket, then we start to figure out I should put the cheeseburger down and slowly back away. That's something that's going to be long for my health. Right now, we got a pill. You take a cholesterol pill, you take this pill, you that pill. And again, starts hitting your pocketbook a little bit more. I think people make those choices. We start to become a little bit healthier. The whole system starts to get healthier, fixed, and things like that. So I believe that's the way we need to go, is make ourselves more accountable for it. But it causes these little mini waves, and we do actually see them most specifically on smaller places, quite frankly. Yeah.
And Kevin, I agree with you 100%. I think you're going to start seeing more employers add surcharges on. So just like it's become more common in recent years to be able to have a smoking surcharge, right? If you're a smoker, your employer is going to charge you a surcharge for your health insurance. And you saw what Delta Airlines did, for example, for the employees who chose not to get COVID vaccinated. They charged them a surcharge. I think you're going to start seeing more of that because the employers who predominantly drive the majority of the health insurance marketplace in this country are, they're being squeezed also as insurance rates and start to climb and the usage begins to grow. So they're going to try to find ways to make sure that their employees are healthier. And I think that that's going to reduce their costs. It's going to reduce their turnover. It's going to reduce their staffing issues. So I think you're going to see a lot more engagement on the employer side than you have in the past.
With the current market conditions, staring down the barrel of increased interest rates, inflation, my guess is that more people are going to be signing up for high deductible plans because the way those look on the sheet you get when you pick your health plans is it's going to cost me less, right? And they're not considering the overall cost of hitting a portion of that deductible every year. And Kevin, I also noted that this year there's been more plans with that are high deductible plans, but when you meet your deductible, you're still on the hook for a 20% coinsurance, which I thought was really interesting to try and maybe meter out that wave, or at least keep people from feeling like it's a free healthcare year because I had a baby.
Right. Well, and the number of plans that are offered, through employers have shrunk, and I can tell personally that 10 years ago, 15 years ago, you had a choice of 6 different plans, and then it was 3 different plans. Now it's 2. And, it wouldn't be surprising that, here's your plan. And maybe it's high deductible, maybe it's not, but certainly our choices are less. And you're right. Everyone's in a different place in their life with their kids. And, if you're playing sports, you're at least 2 emergency room visits for sure this year. So why not get the gold plated plan? And when they go off to college and you're like, well, okay, my wife and I are pretty healthy, we probably don't need that. So you move around. But simply the choice that you have now is getting more and more limited, again, to put more skin in the game. I do think that's healthy for the industry, quite frankly. So I don't discount that at all. But it's being forced upon people, no doubt about it.
Yeah. Your kids must be better at sports than mine if you're only getting to the ER twice a year.